Hi, my name is Mylam and I'm going to talk about Seesaw Nystagmus complications. First, the definition. Seesaw nystagmus is a perpendicular oscillation that consists of the elevation and intorsion of one eye and a depression and extorsion of the fellow eye that alternates every half cycle. This striking and unusual form of nystagmus may be seen in patients with chiasmal lesions, suggesting loss of the crossed visual inputs, fibers of the optic nerve at the level of the chiasm, as the causal lesion in the rostral midbrain.
Thank you very much for coming. Appreciate it an awful lot. Derek has had MS for a few years and he's on beta-interferon and is doing reasonably well, but he has an unusual eye movement disorder that is usually pathognomonic of MS called an internuclear ophthalmoplegia. So when you're examining someone with MS, you look specifically at every examination. So Derek, if you don't mind, can you look at my finger here? So at rest once more, there's no evidence of ptosis. There's no square wave jerks and the pupils are equal. So if I could get you to keep your head still, please, Derek, and look to your left. So he's got some nystagmus on lateral gaze there, as you can see, more marked in the left eye than the right, which is the big hint here as to whether there's an underlying right-sided INO looking to the left. But much more obviously, can you look now to your right? He's got very marked nystagmus in his right eye with a failure of adduction of the left eye. Left, right, left, right, left, right, left, right, and back in. So he's actually got a bilateral internuclear ophthalmoplegia due to MS plaques in the MLF, or median longitudinal fasciculus, in the brainstem, connecting the third nerve in the midbrain and the sixth nerve in the pons.
Applications in medicine. The information collected from the investigation gave doctors additional information for possible causes for the diseases mentioned. Also, doctors can now be prepared to treat or to help the baby and the mother by detecting a mutation through a whole exome sequencing of DNA.
Polyhydramnios is a pregnancy complication in which there is too much amniotic fluid inside the womb. Amniotic fluid surrounds the fetus inside the womb and plays a critical role in the process of fetal gestation. It promotes fetal growth, insulates the womb from heat loss, and acts as a protective cushion around the baby. In a normal pregnancy, the amount of amniotic fluid should stay within a certain range. Polyhydramnios is a condition that occurs when the volume of amniotic fluid exceeds that certain level. Polyhydramnios is diagnosed in approximately 1% of all pregnancies, which makes it uncommon but not rare. Most cases of polyhydramnios are classified as mild and only involve a small amount of excess fluid. There are usually no symptoms associated with mild polyhydramnios. Moderate or serious cases usually do cause physical symptoms. The most common symptoms include swelling in the feet and ankles, short breath or difficulty breathing, heartburn, and abdominal discomfort. Serious cases of polyhydramnios can cause a number of risks and complications. The most significant complications associated with this condition include prematurity, fetal macrosomia, fetal malposition, and umbilical prolapse.
Pros and cons. Nystagmus caused by the mutation tends to be mild, so it may go away on its own. There isn't a treatment that fixes gene mutations. Cases can complicate leading to the death of the fetus.
DNA rarely makes mistakes, but it can happen. A point mutation changes a single base. This can change the whole amino acid, or, depending on its position, could go unnoticed. Other mutations can be more damaging. A deletion removes a base, but also causes a frame shift, which changes every amino acid after the mutation. Originally, the codons would be formed in this pattern. But after the deletion, the amino acid sequence will change because the bases shift by 1. The resulting protein will likely be non-functional. An insertion adds a base, but also causes a frame shift, which changes every amino acid after the mutation. Originally, the codons would be formed in this pattern. But after the insertion, the amino acid sequence will change because the bases shift by 1. Again, the resulting protein will likely be non-functional. Lastly, an inversion will invert a segment of DNA end to end. Watch this section closely. Each base has been moved around. Again, these mutations have the potential to be harmful, but not all mutations have an effect on protein. Remember, during translation, a start codon must first be read to begin coding the protein. If the mutation happens before or after the protein coding sequence, there will be no effect on the protein. Mutations must occur in the coding section of DNA to affect protein synthesis. Otherwise, nothing happens. Thanks for watching this episode of Teacher.
Conclusion. This recent information about the effect of the mutation of the MAGED2 gene is important to consider so doctors can give a good and complete diagnosis and also give the best care during the pregnancy. It is a gene mutation, so there isn't a treatment for the MAGED2, but what can be treated in the polyhydramnios is the effect produced in the Bartter syndrome. Also, this disease is not normally dangerous or lethal.
Antenatal care is the care of pregnant women, and this is provided by trained healthcare professionals. And in Kuwait, this is done by the doctors, and usually in hospital or in clinic settings. Antenatal care has to be individualized according to the risk factors which are present in a woman, so it's different for different women. These risk factors can be as a result of the patient herself, which she may have some medical conditions like high blood pressure, diabetes, asthma, heart problems, or just vitamin deficiencies. Or somebody may have infections like HIV or hepatitis. Some women, they may just be high risk because of obesity, that's overweight. and some women are high risk because they smoke. The others mainly as a result of their mental health problems such as depression. Sometimes these risk factors can happen as a result of particular pregnancy itself. For instance, she's got twins. For instance, this baby is growing too big. We call it large for gestational age. Or the baby that's growing small, which is small for gestational age. And this can also happen as a result of, for instance, the fluid around the baby is too much or fluid around the baby is less, or when her membranes rupture before time, and as a result of diabetes developing in pregnancy, or preeclampsia or antepartum hemorrhage. These risk factors can also happen as a result of previous pregnancy history. Previous pregnancy problems can also put a woman in the high risk category. Family history of congenital abnormalities. So this is another one. A family history of genetic disorders. So they can all make a woman high risk. High risk or low risk, we do not know sometimes until the pregnancy is over. So that's why we have to follow up every woman and provide antenatal care which is high quality. It's variable. Like I said, some women are high risk, some women are low risk. So as we follow on, we need a first booking visit, and follow-up visits are tailored according to what the needs of a woman. Gestational diabetics, we need to really see them almost every 2 weeks because they need to be closely monitored. We need to make sure their blood sugars are normal. Same with those women who develop preeclampsia. We sometimes have to see them once a week, twice a week, because it's to make sure that the blood pressure is under control. So it all depends on how the progress of pregnancy is.
Thank you.